So far, we've been discussing the principles and components of the immune system and testing methodologies. Now we're going to move on to the actual immune disorders. So the first chapter that discusses this is chapter 14, in which we'll be covering hypersensitivity. In chapter 14, we'll be discussing an introduction to hypersensitivity, the hypersensitivity categories, and immunologic mechanisms, clinical examples, treatment, and lab testing for hypersensitivity reactions. So in the previous chapters, we were discussing the immune response, and it's described as a defense mechanism by which the body removes potential harmful antigens. But in some cases, the antigen can persist and the immune response can cause damage to the host. This type of reaction is called hypersensitivity, in which the exaggerated response to typically harmless antigen results in injury to tissue. It can cause disease or even death. There are four categories of hypersensitivity. Type 1, also known as anaphylactic hypersensitivity. Type 2, which is antibody-mediated cytotoxic hypersensitivity. Type 3, complex-mediated hypersensitivity. And type 4, which is cell-mediated hypersensitivity. And we'll be discussing these in a little more detail in this chapter. With the hypersensitivity reactions, they're further categorized into different groups. Type 1 through 3 are classified as immediate hypersensitivity reactions because symptoms develop within a few minutes to a few hours after exposures to the antigen. Type 4 hypersensitivity is sometimes referred to as delayed hypersensitivity because this manifests after 24 to 48 hours after contact with the antigen. So first we'll look at type 1 hypersensitivity. In this reaction, it's also known as anaphylactic hypersensitivity. An exposure to an antigen induces production of specific immunoglobulin, IgE, then that binds to receptors on mast cells and basophils. Subsequent attachment of the antigen to adjacent cell-bound IgE results in degranulation with release of chemical mediators that produce the characteristic allergy symptoms. So type 1 hypersensitivity is typically thought of as allergies. The type 1 hypersensitivity reactions typically occur within minutes after exposure to an allergen. And as I just mentioned, the components that are involved with this reaction include IgE, mast cells, basophils, and eosinophils. Type 1 hypersensitivity occurs in two major phases, the sensitization phase and activation phase. In the sensitization phase, the IgE antibody binds to receptors called Fc epsilon R1, which bind the fragment crystallizable region of the epsilon heavy chain. Large numbers of these receptors are found on mast cells and basophils. Langerhans and dendritic cells internalize and process allergens from the environment and transport the allergen MHC class II complex to local lymphoid tissue, where synthesis of IgE occurs. Of the various cells involved in the sensitization phase, mast cells are the principal effector cells of immediate hypersensitivity. These cells are found throughout the body and in most organs, and they tend to be concentrated around the small blood vessels, lymphatics, the nerves, and glands. In the next phase, the activation phase of the response, adjacent cell-bound IgE molecules are cross-linked by bivalent or multivalent antigen, and this causes aggregation of the surface Fc epsilon R1 receptors. This action then initiates complex intracellular signaling events involving multiple reactions. The chemical reactions that occur as a result, one in particular being the influx of calcium, triggers rapid degranulation of mast cells and basophils, which then in effect release chemical mediators that have been previously made and stored in the granules. One of these chemicals that are released is histamine, which I'm sure you're all familiar with. and histamine comprises approximately 10% of the total weight of the granules in mast cells. These substances are referred to as primary mediators. Other primary mediators include substances you've probably heard of as well, such as heparin, and then eosinophil chemotactic factor of anaphylaxis, neutrophil chemotactic factor, and proteases. Each of these have different effects, and it's summarized in Table 14.1 in your textbook. As a result of these chemical mediators being released, allergy symptoms are then produced. Common allergens that induce these type of hypersensitivity reactions include pollen, mold spores, animal dander, dust mites, insect venom, certain foods such as peanuts, shellfish, and dairy products, certain drugs such as penicillin, and latex. Each of these can induce different types of reaction depending on the route of entry. The clinical manifestations caused by release of inflammatory mediators from mast cells and basophils vary from localized skin reactions to a severe systemic response known as anaphylaxis. The symptoms of hypersensitivity type 1 reactions depend on variables such as route of antigen exposure, dose of allergen, and frequency of exposure. If an allergen is inhaled, it's most likely to cause respiratory symptoms such as asthma or rhinitis. Ingestion of an allergen may result in gastrointestinal symptoms, whereas injection into the bloodstream can trigger a systemic response. Rhinitis is the most common form of allergy, and it affects between 10 to 30% of the population worldwide. Symptoms of rhinitis include sneezing, rhinorrhea or runny nose, nasal congestion, and itching of the nose and eyes. This condition is usually just annoying, but there are complications that can occur, such as sinusitis, otitis media, which is an ear infection, eustachian tube dysfunction, and sleep disturbances. Some of the aforementioned allergens that cause rhinitis include pollen, mold spores, animal dander, and particulate matter from the house, such as dust mites. Local inflammation of the skin or dermatitis can also be caused by type 1 hypersensitivity reactions. So these reactions can manifest as urticaria or eczema. So urticaria are known as hives, so they're wheeled or flared appearance of the skin. And then eczema is a skin rash that results from exposure to these allergens. The first line of defense for treatment of type 1 hypersensitivity reactions is avoidance of the allergens, but in some cases this can't be done. So with patients that suffer from certain type 1 hypersensitivity reactions need to be treated with drug therapy such as antihistamines, bronchodilators, mast cell stabilizers, or corticosteroids and epinephrine. Monoclonal anti-IgE antibody is also a therapy that's used for some patients. Particularly, it's been successful with patients with asthma. Another treatment includes allergy immunotherapy, or AIT, and this involves administering increasing doses of allergen gradually to the patient. Evaluation of patients with an allergy begins with getting a medical history and physical examination to assess the patient's clinical symptoms. These assessments are then followed by specific in vivo skin tests, in addition to in vitro tests for IgE antibodies to confirm the presence of an allergy and to determine which allergens the patient is sensitized to. The in vivo skin test begins with direct skin testing because this procedure is less expensive and more sensitive than serologic testing, and it can provide immediate results. In these tests, the clinician uses a needle or a sterile pricking device to introduce a small drop of allergen extract into the upper layers of an individual's skin in the inner forearm or on the back. Typically, a panel of allergens is routinely used, with each applied to a separate site 2 to 2.5 centimeters apart. A negative control is also used that consists of allergy extract and a positive control of histamine. After 15 to 20 minutes, the clinician examines the testing spots and records the reaction. In a positive reaction or test, a wheal and flare reaction will appear at the site where the allergen was applied. Allergen-specific IgE testing on serum is a safer alternative to perform than in vivo skin testing, since it just requires the use of patient serum versus testing directly on a patient. The original commercial testing method for determining specific IgE to various triggers, including ragweed, trees, grasses, molds, animal dander, foods, and insect venom, was a radioallergosorbent test known as RAST. And this was a radioimmunoassay. So these are the methodologies we spoke about in a previous chapter. With RAST testing, the patient serum sample is incubated with a paper disc to which various allergens were covalently linked. Then, following a washing step, removing unbound antibody, bound IgE was detected by adding a radio-labeled anti-IgE. And after a second wash step, the amount of radioactivity detected was measured by a gamma counter and is proportional to the amount of allergen-specific IgE in the patient sample. Now, other immunoassays have been used without the use of the radioactive labels. The newer testing uses enzyme labels that react with substrates to produce fluorescence, chemiluminescence, or colorimetric reactions rather than the radioactive labels. In contrast to the figure shown on the previous slide, in which allergen-specific IgE is detected, tests have also been developed to measure total serum IgE. The first test developed for this measurement of total IgE was a competitive radioimmunosorbent test. This was known as RIST. The RIST used radio-labeled IgE to compete with patient IgE for binding sites on a solid phase coated with anti-IgE. Similarly to the RAS testing for allergen-specific IgE, RIST testing has been replaced by non-competitive solid phase immunoassays or nephelometry assays, which do not require the use of radioactive labels anymore. RIST testing is more beneficial in evaluating patients with other conditions in which IgE is elevated, such as whereas type 1 hypersensitivity mainly involved IgE, type 2 hypersensitivity, also known as antibody-mediated cytotoxic hypersensitivity, involves the key components of IgG and IgM directed against cell surface antigen. Binding of the antibody to the cell surface antigen can have one of three major effects depending on the situation. The cell can be destroyed, the function of the cell can be inhibited, or the function of the cell can be increased above normal. The cell damage that can occur can happen by several different mechanisms, some of which involve complement as well as antibodies. The different mechanisms include activation of the classical pathway of complement that can lead to formation of the membrane attack complex and cell lysis. Opsonization or coating of the cell surface by antibodies can promote phagocytosis of the cell. Or cell damage can result from the mechanism of antibody-dependent cellular toxicity. This is known as ADCC, and it's mediated through binding of IgG antibody to its corresponding antigen on the target cells and to the Fc receptors on macrophages or natural killer cells. The binding, in effect, stimulates the release of cytotoxic enzymes that then destroy the cell. Clinical examples of type 2 hypersensitivity include blood transfusion reactions, hemolytic disease of the newborn, autoimmune hemolytic anemia, Goodpasture syndrome, and Hashimoto's disease. In autoimmune hemolytic anemia, The antibodies can be categorized into two groups: warm reactive antibodies that react at 37 degrees Celsius, and cold reactive antibodies, which only react below 30 degrees Celsius. There is also a rare autoimmune hemolytic anemia condition called paroxysmal cold hemoglobinuria. This condition occurs most often after infection with certain viral illnesses. Patients produce a biphasic autoantibody that binds to red blood cells at cold temperatures and activates complement at 37 degrees Celsius to produce an intermittent hemolysis. Goodpasture syndrome and Hashimoto's disease are autoimmune diseases that result in type 2 hypersensitivity reactions, and we'll be discussing these in more detail in Chapter 15. Hemolytic disease of the newborn is a type 2 hypersensitivity clinical example that we'll discuss here briefly, but it will also be discussed in more detail in your immunohematology course. HDN is caused by the development of antibodies by a pregnant woman to red blood cell group antigens on the red blood cells of the fetus, and these are usually RHD antigens. Exposure usually occurs during the birth process when fetal cells leak into the mother's circulation. This diagram depicts the various pregnancies of a woman in which hemolytic disease of the newborn can occur. It can develop in an Rh positive baby who is born to an Rh negative mother if no treatment is administered. The image on the left, labeled A1, first pregnancy, shows an Rh negative mother producing anti-Rh antibodies if an Rh positive baby's red blood cells enter her circulation late in gestation or during the birth process. In the primary immune response, naive B cells differentiate and the plasma cells secrete mainly anti-Rh IgM. And remember, IgM does not cross the placenta, so this baby is born healthy. Even though the baby is born healthy, memory B cells are also produced. So then in figure A2, the second pregnancy, if the mother becomes pregnant with another Rh positive baby, the memory cells produced after the first pregnancy produce a stronger secondary immune response and secrete mainly anti-Rh IgG, which then can cross the placenta and destroy the baby's red blood cells, resulting in hemolytic disease of the newborn. The last figure on the right, B, the first pregnancy with RhoGAM treatment, shows the alternative method or process in which passive vaccination of the mother with an anti-Rh IgG called RhoGAM during pregnancy and upon delivery prevents the mother from mounting an active immune response, allowing her future Rh positive baby to be born normally and healthy. The direct antiglobulin test is performed to detect transfusion reactions, hemolytic disease of the newborn, and autoimmune hemolytic anemia. In this test, polyspecific antihuman globulin, which is a mixture of antibodies to IgG and complement components, is used for initial testing. If this test is positive, it should be repeated using monospecific anti-IgG, anti-C3b, and anti-C3d to determine. Whereas the DAT is sometimes referred to as the Coombs test, after whom of which it was discovered, the indirect antiglobulin test is also referred to as the indirect Coombs test, and this is used for cross-matching of blood to prevent transfusion reactions. It can either determine the presence of a particular antibody in a patient or type a patient's red blood cells for specific group antigens. The method detects in vitro binding of antibody to red blood cells rather than in vivo binding. The method is a two-step process in which red blood cells and antibody are allowed to combine at 37 degrees, and then the cells are carefully washed to remove any unbound antibody. Antihuman globulin is then added to cause a visible reaction if antibody has specifically bound. Any negative tests are confirmed by quality control cells, which are coated with antibody. The visible reaction that indicates a positive test is the observation of red blood cell agglutination in the samples. Type 3 hypersensitivity, also known as complex mediated hypersensitivity, is a similar reaction to type 2 in that IgG or IgM is involved and destruction is complement mediated. But in the case of type 3 associated diseases, the antigen is soluble. So when the soluble antigen combines with antibody, complexes are formed that precipitate out of the serum. Normally, these complexes are cleared by phagocytic cells, but if the immune system is overwhelmed, these complexes then deposit in the tissues. The complement then binds, causing vasodilation and vasopermeability to increase, thus causing damage to the tissues. The actions of macrophages and neutrophils migrating to those affected areas and releasing lysosomal enzymes are what specifically results in tissue damage. Serum sickness is a generalized type 3 hypersensitivity reaction. It results from passive immunization of humans with animal serum. It produces antibodies against the foreign animal proteins in patients and results in immune complexes forming and depositing on tissue. Before the advent of antibiotics and vaccines, serum sickness was observed more often because horse antiserums were used to treat infections such as diphtheria, tetanus, and pneumonia. Symptoms of serum sickness include headache, fever, nausea, joint pain, rashes, and lymphadenopathy. These generalized symptoms of serum sickness generally appeared 7 to 21 days after injection. Usually, it was self-limiting disease. Type 3 hypersensitivity reactions can also be triggered by autologous antigens, as seen in several autoimmune diseases. Systemic lupus and rheumatoid arthritis are two examples of these diseases. Patients with these diseases commonly produce antibodies against nuclear constituents such as DNA and histones. They may also produce an antibody against IgG called rheumatoid factor. These autoantibodies combine with corresponding antigen to produce immune complexes that then trigger the type 3 hypersensitivity response. Other conditions that can trigger this type of response can be caused by components of vaccines, bee stings, treatment with certain drugs, and infections such as viral hepatitis and group A streptococcus. In autoimmune diseases such as lupus and rheumatoid arthritis, the presence of anti-nuclear antibodies, testing known as ANAs, is detected by a variety of methods, including indirect immunofluorescence, enzyme-linked immunosorbent assays, and fluorescent testing. Fluorescent stains are also used of tissue sections to determine deposits of immune complexes in tissues. More general methods of evaluating immune complex diseases are those such as measuring complement levels. Type 4 hypersensitivity is the last type we'll be discussing. This is also known as cell-mediated hypersensitivity, and it's also been called delayed hypersensitivity reaction because the reactions peak 48 to 72 hours after antigen exposure, opposed to types 1 through 3 that occur within minutes to hours. Type 4 hypersensitivity differs from the other three types as well in that sensitized T cells rather than antibodies play the major role in its manifestation. Although there are different mechanisms involved in type 4 hypersensitivity, the classic type 4 response involves the Th subclass of T helper cells. There's an initial sensitization phase of 1 to 2 weeks that takes place after the first contact with antigen. Both T helper 1 cells and macrophages are involved in this reaction. Antigen-presenting cells present antigen to the naive T helper cells, which differentiate into the T helper 1 cells. Then these cells release cytokines that attract and activate the macrophages, which induce inflammation. Cytotoxic T lymphocytes are also involved and recruited to destroy target cells. The antigens that can trigger the type 4 hypersensitivity reaction are generally of two types, either intracellular pathogens or contact antigens. The intracellular pathogens can be bacteria, fungi, parasites, and viruses. Contact antigens are those that come into direct contact with the skin and include plants such as poison ivy, poison oak, metals such as nickel, and components of hair dye and cosmetics. Specific examples of intracellular pathogens that can cause type 4 hypersensitivity reactions include Mycobacterium tuberculosis, which is the causative agent of TB, Mycobacterium leprae, which is the causative agent of leprosy, and other intracellular pathogens such as Pneumocystis carinii, Leishmaniasis species, and viruses such as herpes simplex virus. There's a pneumonitis hypersensitivity that causes an allergic disease of the lungs, and this is usually found in individuals who work or have hobbies that involve exposure to antigens such as moldy hay, pigeon droppings, or compost. It's caused by the inhalation of bacterial and fungal spores. Examples of these types of hypersensitivity conditions include farmer's lung disease, bird breeder's lung disease, and humidifier lung disease. And some of these we'll be discussing in more detail in microbiology. Contact dermatitis is another specific example of type 4 hypersensitivity. This is usually caused by contact antigens such as plant materials, poison ivy, poison oak, and poison sumac, all of which release chemicals in the plant sap and on the leaves. Allergic dermatitis caused by contact with these plants affects millions of Americans. Other compounds that can produce allergic skin manifestations include metals such as nickel, latex, rubber, formaldehyde, hair dyes, and fabric finishes, along with cosmetics and some medications applied to the skin. Patients who suffer from contact dermatitis present with skin eruptions with redness and swelling, and sometimes papules are produced. So it basically variations of rash on the skin. With this type of hypersensitivity reaction, sensitization of the T helper cells can last for years because of immunologic memory. Conditions are usually treated with topical steroids to reduce the inflammation. Skin testing is used clinically to detect delayed hypersensitivity responses to a variety of antigens. The tests are based on the T cell mediated memory response. So, when antigen is injected intradermally or applied to the surface of the skin, previously sensitized individuals should develop a reaction at the application site. Two common tests include the patch test, which is considered the gold standard in testing for contact dermatitis. This testing should be done when the patient is free of symptoms. Antigen is applied to the skin surface, and a positive test is indicated by redness with papules or tiny blisters. The Mantow method is commonly used for PPD testing. Antigen is injected intradermally, and a positive test is indicated by an induration or raised area around the site of injection. The figures on this slide show an example of the Mantow test, also known as the PPD. In the first image on the left, a purified protein derivative, PPD, is injected into an individual's forearm, which as a result causes a wheal. In the figure on the right, it's after 48 hours, the individual presented with an induration, which is a hardened raised area, and this indicates a positive reaction. In summary, type 1 hypersensitivity involves exposure to an allergen that induces production of specific IgE antibody. This in turn binds to mast cells and basophils, inducing them to degranulate and release chemical mediators. These cause vasodilation, vasopermeability, and other clinical symptoms associated with allergy. Type 2 hypersensitivity reactions involve IgG and IgM antibodies that react with cell surface antigens, causing cell damage by complement, lysis, opsonization, or antibody-dependent cellular cytotoxicity. Cell dysfunction occurs by the blocking mechanism of binding of ligand to cell surface receptor or by overstimulation of a cell's function. Type 3 hypersensitivity reactions involve small immune complexes containing IgG or IgM antibodies precipitating in the tissues and activating complement. Neutrophils are then recruited to the sites of the immune complex deposits, where they release lysosomal enzymes that cause inflammation and tissue injury. And finally, type 4 hypersensitivity reactions involve antigen sensitized T cells, releasing cytokines that induce inflammation and tissue damage.